Burn management is a complicated process as the injury can affect the entire body. First-degree burns only involve the epidermis of the skin. These burns do not blister, they are red in color like a sunburn, they have normal capillary refill time, and also have normal sensation. These burns heal naturally and do not scar and are not calculated in the total body surface area. Second-degree burns involve both the epidermis and the superficial dermis. These burns are pink and often blister. Because of the exposed nerve endings, these burns are painful to the touch. As long as these burns are kept clean with appropriate dressings, they will heal with minimal scarring without the need of any skin grafting. Third-degree burns extend deep into the dermis. These burns have a blotchy red appearance. These burns also often need surgery for repair and healing. Fourth-degree burns are white or black in color. They are leathery to the touch, and they extend through the entire thickness of the skin into the underlying fat and tissues. In order for healing, these burns require surgery. Burns are complicated. After a burn injury, inflammatory mediators such as histamine and prostaglandins are released, which cause increased capillary permeability, which leads to burn edema. The increased capillary permeability causes a rapid transfer of water, inorganic solutes, and plasma proteins between the intravascular and interstitial spaces, and this is referred to as third spacing. Due to third spacing, it is critical to replace the fluids in order for the patient to heal. Parkland's formula is a formula that is used as a basis and a guideline to initial fluids after a burn injury. Within the next few minutes, we will review a case study which uses the best evidence and practice.
My name is Dr. Parker, and I'm the attending for Mr. Jones right here. Mr. Jones was admitted to our burn unit after he received second and third degree burns to his lower extremities after he fell asleep in his reclining chair while he was smoking. Nurse Nancy and I just completed the Lund-Brauer chart, and we determined that the total body surface area of his burn was 25%, which qualifies him for fluid resuscitation. I would like you to use the Parkland's formula to calculate the amount of fluids that he will be needing. Pay close attention to his urine output. Make sure that it stays between 30 and 50 milliliters every hour. If it drops below 30, increase the rate of the fluids by 20%. And if that does not increase the urine output to remain in that 20 to 30 milliliters an hour, call me and we will see if he qualifies for our colloid supplementation protocol.
Okay. And do you want me to use the lactated ringers?
Yes, I do. Do you remember why we use LR as our choice of fluid?
It's because the byproduct of lactate metabolism in the liver counteracts acidosis, acting as a buffer. LR is similar to human blood. This is important because the third spacing of electrolytes and solutes.
Okay, perfect. Well, let's start those fluids and call me if there's any problems.
Will do.
Okay, so remember Parkland's formula is 4 milliliters per kilogram times your total body surface area. Mr. Jones weighs 90 kilograms, and this was the percentage of the burn. So we're going to calculate the formula so we know how much fluids to give him in the first 24 hours, which is the most critical time after a burn. So we'll go 4 times 90 times 25, and that equals 9,000. Okay, so that's our total amount of fluids we're going to give in the 24 hours, but we want to give the first half in 8 hours. So we're going to divide that by 2, which gives us our 4,500. So that's how many we're giving in the first 8 hours, and we want to find our hourly rate, so we're going to divide that by 8, and we get 563 milliliters per hour. So this is the starting rate of the LR that we're going to start his fluids at. And then just keep your hourly output and notify me if urine output does not stay between 30 and 50 milliliters per hour. Okay?
Okay.
Thank you.
All right, Mr. Jones, I'm going to be giving you some fluids now. I'm going to be putting in 563 milliliters an hour. This is just very important after a burn. We need this to happen so you can get feeling better. So Mr. Jones' urine output has dropped below 30 milliliters an hour. And Dr. Parker has instructed me if it does that, that we need to increase his fluid intake by 20%. So if we do that, that would give us 675 milliliters an hour.
How is Mr. Jones doing?
Well, I increased his fluid intake by 20% 2 hours ago, and as you can see, it's still below 30 milliliters an hour. So what should we do at this point?
Well, there's promising results coming from studies using colloid supplementation. So what I want you to do is we're going to use 5% albumin at 1/3 of our current rate, and you're going to run the LR at 2/3 its rates. The idea of adding colloids in resuscitation periods is it decreases the total amount of fluid needing. If we keep increasing LR to maintain our urine output, then that might lead to complications such as pulmonary edema and abdominal compartment syndrome. And do you know how colloids work? Do you know what the theory behind colloid use is?
Not entirely.
Okay, so colloids, they increase the vessel's osmotic pressure, which causes limited capillary leakage. The fluids in the interstitium is retained and returned to the vascular space. As third spacing decreases, it helps to deter the development of complications such as the pulmonary edema and the abdominal compartment syndrome. So I will be back in a couple of hours to assess the outcomes of the albumin protocol. Okay?
Okay.
All right. Thank you.
Hello, Mr. Jones. We're going to add 5% albumin now into your IV.
Hey, nurse. How is Mr. Jones doing?
According to his urine output, he's doing really well. He's increased to about 40 milliliters an hour.
Okay, that's really good. That's perfect. That's what the results we were hoping for. So I want you to continue to keep meticulous watch on his urine output. If for some reason that the urine output increases above 50 milliliters per hour, it's okay to decrease the hourly rate of both the albumin and the lactated ringers by 10%. But I think Mr. Jones is showing promise, and I think as we continue to watch him, he'll make a good recovery.
It is very important to calculate the total body surface area accurately to determine the initial amounts of fluids to be given to a burn patient. Rule of 9, rule of palms, and the Lund-Brauer chart are all ways to determine the area of the burn. Nurses need to be trained on their unit's preferred method. It might be helpful to have more than one person calculate the surface area of the burn to ensure that there is no over or underestimation of the burn. A study was conducted by Pavarzi in 2013, which indicated that when the surface area of the burn is calculated carelessly, the amounts of fluids can vary greatly, increasing the risk for complications. In 2010, Greenhall conducted a survey that showed that 89% of respondents used Parkland's formula as a starting point and then would increase or decrease fluid rates based on urine output. In the case study presented, the fluid resuscitation protocol was adapted from the protocol at the University of Utah's Burn Center. Two different studies, one by Farkglass in 2012 and another by Lawrence in 2010, showed that adding colloids increased urine output and decreased complications known as fluid creep, which is a term used for excessive fluid resuscitation leading to other complications such as abdominal compartment syndrome. To further improve this protocol, nurses could be advocates for a computerized system that monitors urine output and will indicate when fluids need to be changed. It could also send alerts to the attending physician so that the albumin protocol could be started and implemented faster. Nurses can also help to establish studies to determine if adding colloids right at the beginning of fluid resuscitation is beneficial to the overall recovery of burn management. Colloids are expensive, they have short half-lives, and need specific storage requirements, leaving reason to believe that this might be the reason as to why there is not much research currently. Not only can nurses participate and organize in these studies, but they can also present new ideas and research published to those in their units. It is critical for nurses to remain up to date on the most critical research and present the research to others so that the best care can be implemented, and this will ultimately provide benefit to the patient's well-being.